Welcome to Medicine Made General, a podcast for patients brought to you by the Johns Hopkins Division of General Internal Medicine. I'm Katie Cavanis Crowley, and I'm here with my co-host, Dr. Bimal Asher.
Here with Medicine Made General, one of the things that we often talk about is that healthcare is not just about treating diseases, but it's about helping people live their best lives. Today, we have a very special guest who is going to be talking about a group of patients who often fall through the cracks, and specifically young adults or young children as they enter adulthood. With complex medical problems. So we have Sarah Mixter, who is board certified in both pediatrics and internal medicine. And we're excited to have her on the podcast.
For our listeners who are joining us who aren't as familiar with you, could you tell us a little bit about your journey into medicine? What drew you to MedPeds, and specifically what drew you to focus on children and adults with complex medical needs?
I was one of those weird kids who, despite the only doctors I knew were my doctors, but I kind of always knew I wanted to go into medicine. I, from a really early age, wanted to be a pediatrician, and I had a very clear focus. Even in elementary school, I was like, I want to be a pediatrician working with underserved patients, because I don't know why a 9-year-old says that, but that was my focus. But I think once I started being in training, moving back and forth every few months between pediatrics and medicine, I think, I always want to know, what am I bringing to this encounter? What are my special skills? And I think, being a pediatrician in internal medicine and being an internist in pediatrics, I think I was really drawn towards the patients on either extreme, right? The kids and peds who were about to transition and the stress that was putting on their families, and how I could uniquely help them understand what it might be like when they got to medicine. And on the flip side, on medicine, we'd have the 25-year-old with, a complex genetic disorder admitted with pneumonia, watching The Jungle Book. And everyone was like, how do I take care of this person? I'm like, you just take care of them.
Thank you for providing that background. I wanted to, just talk more about the transitions that you had previously mentioned. Many families, just starting in childhood, they have pediatricians, they've known them for years. Why can that transition from pediatric care to adult care be so challenging?
Yeah, so I think it's a few things, right? One, I think we can be very focused on the medical transition, right? But there's a lot of change happening for young people and families at that time. And so I think, people could be going off to college, graduating school, there's insurance changes, there are all kinds of things that are happening. There's this expectation around this age where you transition that you're kind of starting out on your own, or perhaps if that's not developmentally appropriate for someone, at least there's other big changes going on in their life. And so I think that, one, it's part of this very tumultuous time. And while all those changes are happening, we're saying, oh, and the medical team that has taken care of you your whole life, we'll just get you all new people, right? So I think in this, it's going on in this background of intense change. And then I also think that there is this trust that patients and families build with their pediatric teams over time. They might be seeing the same providers who gave them a really hard diagnosis or who helped them through health crises. They've known them for a long time. It's all they've ever known. And again, we're saying, okay, all those relationships, sometimes all your team, right, is going to completely switch to new folks. So it's a lot of change all at once, and it can feel like a very big rupture. I also think one of the things I've heard from families over time, and from patients, is that it kind of feels arbitrary a lot of times, right? They're the same person with the same medical problems they were when they were 21 and 364 days as they are when they're 22. And yet you're saying all these people, right, aren't going to be able to take care of them anymore. And so I think that also, even if you prepare people for it, I think there's this sense of well, why does this have to happen? And then I think the last piece, and this is supported in the literature, and obviously this is not universal, but there can be a real significant lack of knowledge and lack of comfort among adult trained physicians in taking care of people with intellectual and developmental disabilities, in caring for people with what we've seen historically as like pediatric problems. Even if more and more of those children are living into adulthood, even if these things are becoming lifetime problems, I think there is a sense, again, that has been backed up in studies where, there are a fair number of internists, family physicians, other adult physicians who say, I didn't learn about this and I don't feel comfortable with this. And that's absolutely true of patients with these kind of childhood onset conditions. But quite frankly, and this is something I think we kind of need to deal with like as a group, that's even true of disability in general. Like when you do surveys of, doctors' offices and physicians about, would you take XYZ patient with a disability into your practice? It's not universal, but there's sometimes in some studies, a small majority, at least a large number who say, yeah, I'm not the right doctor for you. That's actually the name of the paper. I'm not the doctor for you. So I don't want to plagiarize it, but, just this idea that it's too hard, it's too complicated. And I think the patients I focus on are a subset of that problem and that challenge, where it can be even more true related to the fact that some of them have conditions that maybe an internist hadn't heard about since medical school.
So is there a kind of a general rule among pediatricians on when they may say, okay, you've got to go see an adult provider? I mean, is it a little gray? Do some pediatricians say, I'll see you until you're 45 or,
Yeah, I think that's also another problem that families face, because I think you're absolutely right, Bimal. It can be very provider dependent, practice dependent, institution dependent. There's some institutions in the US where it's like very hard and fast. When you're 18, you're pretty much done in the pediatric setting. Here at Hopkins, our kind of rule, and of course there are exceptions, but our general rule is that you're going to be moved on from pediatrics once you turn 22. But I think the fact that there are exceptions and people who are flexing those things, and some groups that are saying, let's open up the idea of lifespan care, right? I think that's wonderful. That's kind of what I do myself, but I actually think that can be confusing for families. I think the other area that sometimes gets confusing is that I explain this a lot to families, like many of the surgical specialties may continue seeing young adults, right? And so when I explain that to families and patients, I say, look, like if I wanted to be a pediatric cardiologist, right, I would do a pediatrics residency and then I would become a cardiologist. And so I'm a pediatrician first, a cardiologist second. But if I want to be a pediatric heart surgeon, I become a surgeon first, and then I specialize in pediatrics. And so I think those folks have done a full, general surgery, general neurosurgery, whatever training. And so I think that actually does create this space for some of those pediatric surgeons to have more of a lifespan practice. That's also something that kind of will throw families off when I'm explaining this to them. I'm like, oh no, you can continue seeing your orthopedic surgeon because he's going to keep following you for your, neuromuscular scoliosis or your hip dysplasia. But yeah, everybody else, we got to move on. And I think that can also make the system seem even more opaque than it truly is.
I was just curious, what do you, like speaking directly to other physicians, what do you wish every adult primary care physician understood about caring for patients with, developmental disabilities, complex childhood conditions, etc.?
I think about that a lot because, obviously this is where I've chosen to build my niche, and I would love our program to continue to grow. And, I'm in touch with folks around the country who are doing this as their kind of like specialized practice. But when we look at the supply and demand, right, there's no way that clinics like mine, even if we keep growing, are ever going to be able to meet the needs of patients with complex childhood onset conditions, of patients with intellectual and developmental disabilities as they age into adulthood. So the way I try to frame things for kind of your average adult physician is to have them really think about their practice, right? Like your average internist, your average person who's taking care of adults is taking care of a lot of really complicated patients, people with heart failure and diabetes and kidney disease, like all of these things. You're coordinating care with multiple physicians and other teams. These are not simple patients that we kind of take care of on a day-to-day basis. And so I think that most of us have the skills to take care of complex patients, right? It's kind of part of like the bread and butter of internal medicine. And I think for a lot of family physicians as well who are practicing primary care. And it's just about kind of like taking those skills and saying, yeah, okay, maybe I don't know very much or anything about a 5p deletion, right? Or, even slightly more common Down syndrome. But there are resources where you can find out kind of the clinical information that you need to kind of navigate those diagnoses. And you're really using a lot of the same skills. So I think just encouraging a reframing is kind of like at the core of how it encourage people to kind of embrace these patients as much as possible.
Sarah, you've created something you've termed the PACT Clinic.
Yeah.
I wonder if you can tell us specifically about, what does PACT stand for, and what do you see as both the goals of the clinic and where you would want it to go?
Yeah. So PAC stands for pediatric -informed, so the I is lowercase, adult care and transition. And so I think the goals are kind of in the title. I think the idea is to be providing adult longitudinal care, mainly primary care, though we have some patients we see in consults who see a local primary care physician for patients. And then also we have a lot of patients where we kind of guide them through the transition process. So they might come to us, in their early 20s, maybe they've aged out of care in pediatrics, but haven't necessarily replaced those providers, or they're really heading into the transition. And so really being systematic, thinking about what specialties do we need to help you get established with on the adult side, and really guiding them through that process medically. But then I also think a cornerstone of the program, and I think this really that comes from like what I kind of like grew up in as building my interest in medicine, is thinking about the whole patient in their family, in their community, knowing the types of programs they're interfacing with, the types of paperwork they're going to need, just like these additional resources, and like this is kind of contrary to my last point, but the additional complications that these patients come with, the things that we really need to understand to help their care move forward. I always say to folks who kind of ask like, oh, how did you like gain the knowledge that you have about these resources? I don't think that it is about me being able to solve every resource problem that my patients have. But me having a working knowledge of what the programs are out there, of what kind of the types of agencies and support organizations my patients are going to be working with, is like hugely validating for families, right? I think you earn this, like, you get this like instant cachet with a parent when you're like, oh, who's your DDA service coordinator? And they're like, oh my God, you know what that is? So I think that's like really part of the philosophy of the program, that we are really helping think about the whole patient and the whole family in their community. And so I think as I think about like growth of the program, I would love to obviously continue to grow and see more patients, but then also be able to expand those services and kind of bring more of those resources into the program. I also think, this is a population that's in the hospital more than your average, young adult. And so thinking about, we do a lot of like informal consultation on our patients when they're in the hospital, but thinking about making that more structured. Could there be more kind of purpose-built solutions for these patients when they're in the hospital? And I think of that, in the medical sense, but also in the support sense. One of my colleagues in Alabama, they just hired a child life specialist for their adult hospital to really be focused on patients with intellectual and developmental disabilities. And that's like my newest dream, in addition to a few other things. So I think continuing to grow the program, but then also just like continuing to make it more and more wraparound services for patients and their families.
What kind of patients and families does the clinic serve?
Yeah. So we start seeing young people when they have to be at least 16. And we kind of have two major populations. So one is what I would consider kind of the medically complex population. So these are patients who often have multiple medical specialties involved in their care. They often have medical technology dependence. So just like, maybe like I said, tracheostomy and ventilator, a feeding tube, so just a lot going on in their medical care. And then I think of it as like a Venn diagram with the other population that we have a significant group of, which is folks with intellectual and developmental disabilities. Because even if a patient with, let's say, Down syndrome or maybe autism spectrum disorder is not incredibly medically complex, there's often like another layer at least to their medical care. And I think the presence of that intellectual or developmental disability also adds kind of like another layer of complexity to their care. And so some of the most common diagnoses, I already mentioned Down syndrome, autism. I have a lot of patients with cerebral palsy, spina bifida, but it's really a very broad kind of like survey of diagnoses that we serve.
So when a patient and their families, they come to your first visit with you, what does that look like? And how is it different from a typical primary care visit? Or is it different?
Yeah, no, I think it definitely is. And there are some things that are, of course, the same. So getting a sense of the patient's past medical history, who they are, who they live with, like what are their interests, right? These are things I would do for any patient. And obviously, sometimes understanding that medical history is a significant part of the visit. And I'm always very happy when someone has had a lot of their care, in our system. So I'm able to really access their full records. But I think the places that we're a little bit differentiated are first, especially in those younger patients where they are in that transition period, really being explicit about transition planning. So understanding what specialists they see, what specialists will need to transition, what things we might be able to take over in our practice. There's a few things in pediatrics that are managed by subspecialists that in internal medicine really aren't. So tube feeding is a big one. I have a lot of patients who are getting tube feeds and see a pediatric gastroenterologist, and that's just not something that adult gastroenterology really does as much. Or even things like high blood pressure, type 2 diabetes, hypothyroidism. These are things that are pretty much bread and butter, right, for an internist, but a lot of times are managed in specialty care in pediatrics. And so some of that is saying, okay, great. Well, we're actually going to pare down the number of specialists that you see. But yeah, your seizures, we really need to get you in with adult neurology, or, for your congenital heart disease, where are you in the process of moving into the adult congenital heart program, right? So I think there's a big piece of that. And even in those patients who are a little bit older and they've transitioned, we may be taking a step back to say, like, hey, were there things that kind of like fell off in that process? Like you have a shunt maybe, but you haven't seen neurosurgery in 7 years. Like maybe we need to revisit that. So I think the transition process can have a long tail, and we definitely focus on that. And then the last piece is kind of what I alluded to a little bit in those like wraparound services that I think we strive to provide, is this really kind of expanded social history. So, in someone who maybe is still in school, what's the plan for when you're leaving, when you're graduating school or receiving your certificate, when you're about to age out? What are you going to be doing for a day program? What are you going to be doing if you want to move out of the home and perhaps into like state supported residential services? Where do you guys stand in that process? A fair number of my patients require increased caregiving at home. So do you have nursing? Do you have, care aides at home? And what programs do those come through? And then also thinking about your supplies. So if patients have feeding supplies, incontinence supplies, making sure we're kind of getting set up to take all those things over. So there is like a lot of kind of like bookkeeping as well, just to make sure all the things that are helping support this person, like living in their community, living with their family, being at home or wherever they're living, are being kind of seamlessly moved into our practice.
Speaking from experience, I have a brother who has autism, and I have watched my mom over the years. She has just been such an amazing advocate for him. And I've also watched her try and navigate our healthcare system. I was wondering, are there some things that families regularly come to you with, like questions that they wish they understood more about the healthcare system?
Yeah. So thank you for sharing that, Kate. I
Yeah.
think that is really such a huge theme. And I will be like a little glib, but my overall philosophy, I say this to caregivers, I say this to like other advocates I work with, and I think this is something that a lot of families feel. I think my guiding principle, and I think a lot of this is a lot of what families wish we knew or wish we could support, is I just feel like it shouldn't have to be so hard, right? Like our system is so hard. There is this principle called care mapping, which if people haven't heard of it, I would encourage you to kind of like Google it, complex care mapping. But it's basically where caregivers will kind of like visually represent their child's kind of like care universe. So sure, it'll have their maybe like 4 or 5 medical specialists, but it will also have their community agencies that are supporting their day program, and the legal program they're working with for medical decision making, and someone's in school, the educational advocate they're working with, and just like the scope of things that we expect caregivers, and mostly families, to coordinate is really, I think, I won't say crazy, but it's a lot. And I think that, again, I don't think that as a physician in this space, it is not my place to solve every problem, but understanding that scope and understanding where families are coming from and the types of things they've had to navigate, I think makes a huge difference. Right now we're dealing with a lot of cuts in the state, or threatened cuts to the Developmental Disabilities Administration services. And just being able to speak with families about that and the impact that is going to have on their loved one's care and life. I think there's also a role, I think, to like be an advocate and be a voice. But I think just having a basic understanding of like what reality is like and what it might mean to say, oh, okay, like, go do this appointment, and then a few hours later, go do that appointment. Just like sometimes we ask people to do things that are just like not realistic. So I think being able to, as much as possible, understand or imagine like the reality of complex care on a person and a family, and like what life is like in a home, I think makes a huge difference. And I think that is really meaningful to families. And I think, yeah, I think that just meeting people where they are. And I think the other thing that I hear a lot from families is a lot of times in medicine, you're kind of seeing an individual and their caregivers like on one of their worst days, right? They're sick, they're stressed out being in your clinic, but that like often there's like a very different life they're living outside of like the medical setting. And just again, kind of being able to imagine that and understand that people with disabilities, like, this is painting a very broad brush, but have very full lives. And in medicine, I think a lot of times we underestimate that, and we kind of don't understand like the full scope of life of our patients kind of outside of the medical setting, which I think really is challenging for patients and for families.
I mean, you've brought up some of the challenges that the families and caregivers face, and Sarah, they've been so involved in their child or loved one's care. How do you, as they transition to adulthood, these patients transition, how do you support the independence and the voice of the patient while also respecting the family?
Yeah, I think that's a great question. And I think it really, a huge piece is kind of meeting the patient and family like developmentally where they are, right? And understanding what is realistic to expect of an individual based on their disabilities and to really avoid underestimating. So I think one of the first things I will always do when I'm meeting a new patient is make sure how that I understand either from them directly or their caregivers how they communicate, right? Making sure they have the devices that help them communicate or the methods that help them communicate available. So we're giving as much possibility as possible for that individual to participate in their care, addressing patients directly, even if you might not think that they can understand everything that you're saying, and really making your default setting to be I am going to engage this person in their care, with inquiry into like what are the best ways to do that if they're not able to tell you. And I think, I do have some patients again who developmentally are not going to be participating in their care, right? Because of the extent of their intellectual disability. But I still address them as a person. I still like greet them when I come into the room, and still like, talk to them, explain what I'm doing when I'm examining them, because that is like the dignity that every patient kind of deserves. I think on my patients who can participate in their care, it is really important to give them an opportunity to do that independently, right? So if I'm getting history from them that I don't necessarily understand, or I feel like there's like more detail, I'll say something like, "Hey, is it okay if I ask your mom a couple questions about how that visit went, just so I can understand it a little bit better?" Right? So we're not saying, "Hey, what you told me was not helpful," or "I'm just going to keep talking to your mom," but kind of saying like, that was great. Thank you for sharing that. I just need like a little bit more information. And then I think also, as much as is developmentally appropriate, giving every patient an opportunity to have private time in a visit separate from their caregivers so that they can share things that are concerning to them that they might not feel comfortable kind of talking about in front of a caregiver. And again, just that like dignity of independence and dignity of choice, I think is really important.
Before we started recording this podcast, I actually called my mom because I didn't really remember this time in my brother's life, when he transitioned from pediatric care to adult care. And so I was asking my mom, what was that like? And from what she told me, it sounds kind of like you're just drinking from a fire hose. It's so much information. Also, I mean, specifically with my brother's case, his insurance changed when he turned into an adult. So
Yeah.
his pediatric care that he had known for 17 to 18 years, now they no longer took his insurance.
Yeah.
So he had to switch to a different clinic, and it's a brand new doctor and they don't know him. I can't imagine that that's just something that only has happened to our family. So for parents of children with special healthcare needs, when should they start thinking about this transition to adult care?
Yeah. So I would say it is never too early to start thinking about it. One thing a parent once said to me is like her goal having a child with special health care needs was always to have an adult with special health care needs, right? And so like as much as possible, even in like elementary school age, right? Like engaging kids again as much as is developmentally appropriate in understanding their medicines, understanding their medical problems, interacting directly some with their physicians. So really starting that at a young age and like building skills, building knowledge, planting the seeds for as much healthcare independence as is going to be possible. And then I think, like that middle school age, is the time where in pediatrics, we really are saying, okay, mom, dad, like we're going to have a little private conversation with your child. And so, again, as long as it is developmentally appropriate, having that time as well, for a patient. And that should be something that parents, if they're not seeing, should be advocating for, right? As long as their child can participate in a conversation, like having some independent time with their physician is, I think, really appropriate. Um, in terms of thinking about those concrete things like your resources, insurance, I think that is like the later teen years because you're absolutely right. Your family is not the only family where, once a person gets on Social Security, then they're eligible for Medicaid if they were not before. And there are many practices that do not take Medicaid. This is a common time where people come into my practice because they no longer have access to the pediatrician they were seeing before because of insurance changes. I think the other thing that's happening around that time, right, is setting up medical decision making, whether that is a medical power of attorney, supported decision making, guardianship. That also really ideally is being put into place around age 18. So when someone reaches the age of majority, something is in place to support their decision making. So I think that stuff really picks up steam kind of in like the like mid to later teens. And then I think of that kind of like 18 to 21 age is where we're starting to truly lay the groundwork. Because I think as much as we can stagger some of the transitions, like that really is better, right? Like I love it when I get a patient who's more like 18, 19. So we can say, okay, like you're going to get to know me. I'm going to be your doctor for a few years, and then your other specialists are going to change. But that's not all happening at the same time. So I think when we can do a staggered process or kind of concurrent care with different teams, like that really helps ease that process. But I think it's something that we really want people to be thinking about like much earlier than we often start now.
So as we start to wrap up,
Yeah.
What is something that you wish every person who listens to this podcast knew about adults with disabilities and complex medical needs?
Yeah. So I think that this is a little bit cliche, but there's like an expression in the biz, right? That if you know one person with autism or one autistic person, you know one autistic person. If you know one person with XYZ condition, like that's just one experience. And so I think generalization is generally not a good idea. And people will tell you how they or their loved one would like to be communicated with, would like to be treated, like the experience they have had, just ask. So I think if there would be one thing to come out of this, it would be that if there's something you don't know or you're wondering about or feels like you're kind of like in the dark about, just ask patients and their caregivers. And I think as long as you're doing that respectfully, like that's the best way to work. I think with anyone, but I think especially in this population.
I really admire the work that you do. And I think last question, if you were given an unlimited amount of money and resources, what would you like to see happen with your PACT clinic?
Oh, that's a great question. So I gave like a little teaser for some of these things, but so I kind of have two hats. Kind of PACT as like my first baby, but I'm also the medical director of our pediatric complex care program. And so my vision is that, at Hopkins, we really become pioneers in like lifespan care, that this kind of becomes one program where people, even if they're seeing different doctors as they age, out of peds and things change, that this program, I have to get a new name because we have two names for each half. Like, but the program really is there for them throughout the whole time. And there's things we have on the ped side, like some more care coordination that we don't have on the medicine side. We also have more of a peds presence in the hospital where we follow people through their inpatient needs, and we're kind of like more officially following them on both sides. On the flip side, on medicine, we have this like primary care continuity that we don't have on pediatrics. So I would love to kind of balance that out, kind of like fill in the gaps that we have on both sides. And then I think along with that, I really have developed an interest over doing this work in how we care for caregivers. And I would, in addition to some of those increased wraparound services I talked about, that I would love to have more of, thinking about how could a program like this support caregivers in their mental health, in bringing resources into the clinical setting, like just like I was doing as a college student, could we have a medical legal partnership to help with guardianship? I have like many, many ideas, but really just making it more and more comprehensive and kind of having, patients and families at the center and bringing resources to them, because it shouldn't have to be so hard. That's really like my guiding principle.
This is Medicine Made General from GIM at Johns Hopkins. Thank you for tuning into our podcast. We hope you found this conversation helpful. Until next time, stay informed, stay healthy.